Assalamu alaikum. This presentation is on how to interpret the 24 hours chart of pH and impedance monitoring in patients with laryngopharyngeal reflux. The upper trace in here shows the fluctuations in the pH level intraluminal in the pharynx and or the esophagus over a 24 hours period. The time would be marked on the x-axis here, and on the y-axis there will be the pH level. There will be a line indicating pH 4 and perhaps another line somewhere here for pH 7. And the pH level would fluctuate during this 24 hours period, sometimes with dips below the pH level 4, which marks an acid reflux. In here you could see several of these dips. On the upper part of the tracing, you would see certain activities recorded by the patient, including, for example, time of sleep, or lying supine, or having meals, drinking or eating, or feeling of certain symptoms. All will be marked on the upper trace. A typical reflux episode, acidic reflux episode, would be shown in the middle trace here, in which the pH level would have an abrupt decline below the pH 4 line, and then a gradual, often in a stepwise manner, return to the baseline, sometimes with a small overshooting at the beginning in here. And in contrast, this abrupt decrease in the pH level, which is corrected almost immediately back to the baseline, is often due to a technical error, due to a loose electrode, for example, or a faulty connection. The pH fluctuations over a 24 hours period would be shown in the lower segment of the chart. The upper 3 or 4 other segments of the chart would be reserved for monitoring the fluctuations in the impedance in the hypopharynx and in the esophagus. There would be pairs of electrodes in the hypopharynx near the upper esophageal sphincter in the esophageal body and above the lower esophageal sphincter area. And the impedance of electric current between these pairs of electrode would reflect the intraluminal bolus, whether if there is, for example, fluid passing through the esophagus, there will be a decrease in the impedance. This will be shown in here. On the other hand, if there is passage of air, like in aerophagia or in belching, there will be an abrupt increase in the impedance. And by following the timing of such changes, you could tell whether these changes are going from lower part upwards or vice versa. Like in here, for example, it started in the lower pairs of the impedance electrodes, and then it progresses upwards gradually, so you could tell that this is a reflux episode of fluid. If it is just a swallow, you would see it going in the other from above downwards towards the lower pair of the electrodes in the lower esophageal sphincter. Methods for monitoring of impedance and pH changes over a 24 hours period developed quite rapidly in the last 2 decades or so. It started with single channel sensors to monitor either pH or impedance within the esophagus, followed by dual channel, again in the lower and the upper part of the esophagus, sometimes combined with pH probes as well. These were useful in the diagnosis and monitoring of gastroesophageal reflux disease, but not adequate for the diagnosis of laryngopharyngeal reflux because there was no sensors placed in the hypopharynx. Multi-channel intraluminal impedance measurement followed with several channels rather than just 2 or even 1 to measure several segments inside the esophagus or the stomach, together with pH monitoring. And hypopharyngeal-oesophageal multi-channel intraluminal is a special type of this, and this is the HEMII-pH, which in addition to measuring the impedance and pH of the esophagus would also monitor such changes in the hypopharynx. The basic difference between these two ways of monitoring changes in the pH and impedance between the multi-channel intraluminal impedance-pH monitoring and the hypopharyngeal multi-channel type is the presence of sensors in the hypopharyngeal multi-channel type inside the hypopharynx above the upper esophageal sphincter. In both methods, there will be several sensors, several electrodes, maybe between 6 and 8, placed at different levels in the esophagus. Occasionally, one would be also placed in the stomach. There will be two types of sensors in there, one for the pH and the other for the impedance measurement. Impedance measurement would entail having two electrodes placed at different parts of the esophagus, just above the lower esophageal sphincter at 3, 5, 7, and 9 centimeters, and also at 15 and 17 above the lower esophageal sphincter. And there will be a pH probe above the lower esophageal sphincter at 5 centimeters above the lower esophageal sphincter. In the hypopharyngeal multi-channel type, there will be, in addition, sensors placed above the upper esophageal sphincter to monitor the changes in the pH and the impedance in the hypopharynx. The baseline impedance level would reflect the conductivity of the mucosa of the esophagus or the hypopharynx, and this is usually in the area of 3000 ohms. If the baseline conductivity drops to below 2000, like 1500 to 2200 ohms, this usually reflects mucosal injury, which leads to free flow of ions and better conductivity, which would reduce the impedance, the baseline impedance of the mucosa. If gas is passing in the lumen, there will be a sharp increase in the impedance, like in here, above 5000 ohms, or 50% increase in the baseline impedance. This would tell that the material inside here is gas. On the other hand, if the impedance drops, like in here, it tells that this is liquid. The impedance here drops to about less than 1000 ohms. So this would the difference between reflux of gas and the reflux of fluids. And the timing of these change in the impedance in the different segments would tell whether this is going from the upper segment down to the lower esophageal sphincter, like in swallowing, or whether it is going from the lower esophageal segment, like in here, upwards towards the upper esophageal segment, like in reflux. This chart suggests a weakly acidic reflux. In the lower segment here, the pH monitoring showed a drop in the pH with a gradual restoration back to the baseline. This drop was still above the pH 4 level, so it's a weakly acidic. If it dips below the pH 4, then it is acidic reflux. At the same time, you could see changes in the impedance at the same time. Starting in the lower segment in here, there is a drop in the impedance, which you can follow in the upper segments of the esophagus and the hypopharynx. This progressively shorter periods of drop in the impedance suggests a reflux going all the way up to the hypopharynx. This chart, this is an acidic reflux type, where you could see that the pH is now below the pH 4 level. So this is acidic reflux. It's associated also with changes in the impedance, again going up from the lower esophageal sphincter upwards. You could see how the associated drop in the pH has also been associated with changes in the impedance due to liquid reflux starting at the lower esophageal sphincter and going upwards all the way almost to the hypopharynx. In this chart, the reflux that is shown and by impedance changes, the liquid reflux that started from the lower esophageal segment and goes all the way up is associated with minimal changes in the pH level, which remains at the pH 7 degree in here. This is a weakly alkaline type of reflux. The pH is about 7, and the reflux associated changes in the impedance, the drop in the impedance, indicates that this is a liquid reflux starting in the lower esophageal segment and going upwards, and progressively the bolus duration is getting shorter due to the clearance by the peristalsis and the gravity if the patient is in upright position. This chart shows a prolonged period of acidity in here with a drop of the pH below the pH 4 level, prolonged period that is actually formed of two different periods in here. So it's an acid reflux. You could see first here a drop in the impedance followed by restoration to the baseline, and then another drop in the impedance in the lower esophageal sphincter segment, and you can follow it upwards all the way. So these are two different episodes of reflux. Both of them are acidic. There wasn't enough time for the pH to be restored to the baseline, so it is called superimposed acid reflux. In this chart, you could see the relation between certain activities recorded by the patient in the upper part of the trace and the pH level in the lower part. For example, the patient's sleep was marked in here. The patient upright position was marked in here. The meals when he is eating or drinking are marked in here, because these segments should be omitted from the calculations during meals and during sleep. And you could see that the patient had marked that he had felt heartburns in these occasions in there. You could see that the patient had quite sharp fluctuations in the pH, dropping quite a bit below the 4 level during the daytime, particularly after meals, for example. These postprandial acidic reflux are shown quite markedly during the day, but during the night time when the patient was asleep, as marked in here, there wasn't much of reflux episodes below the pH 4 level. So this is an example of daytime acid reflux. In contrast, you could see that this period was marked by the patient as sleeping, and during this period you could see that the pH fluctuations had dipped below the pH 4 level quite significantly. Most of the night sleep he had a pH less than 4. This is an example of severe nighttime reflux. Normal values for impedance-pH monitoring was estimated from traces of healthy adults in 24 hours monitoring, taking the 95th percentile as the upper limit of normality. These suggest that a healthy individual would have less than 73 total reflux events in a 24 hours. This is the upper limit of normality. On the other hand, if this individual has less than 40 episodes of reflux in a day, then you cannot confirm that he has a reflux disease. Anything between 40 and 70 would be sort of a borderline degree. The number of acid reflux out of this total, when the pH drops below 4, would account for about 55, less than 55 events in a 24 hours, and the weekly acidic episodes when the pH is between 4 and 7 would be about 26 events in a 24 hours period. The ratio between the acid and the weekly acidic reflux would be about 2 to 1. It would be twice as much in the acid reflux than it is in the weekly acidic reflux. If the patient, of course, is on proton pump inhibitors or had used proton pump inhibitors recently, the ratio may be reversed. Weakly alkaline, when the pH is above 7, is quite rare, and also the superimposed acid reflux is also quite rare, maybe less than 1 episode in a 24 hours. About a third of these 73 reflux episodes would reach the upper part of the esophagus, the proximal esophagus, and some of them would also reach the hypopharynx. The number of events that could reach the hypopharynx in a healthy individual ranges between 0 and 10 events. The median is just 1 event in a 24 hours period. We would also be interested not only in the number of the reflux episodes, but in its duration as well. The duration of the acid exposure, for example, would be calculated by adding up the duration of all the acid reflux episodes when the pH drops below the pH 4 level in the 24 hours period, and divide it by the time monitored, and this would give the most relevant single parameter that we are looking for to establish a reflux disease, the acid exposure time. And if this in a 24 hours is more than 6%, then this confirms gastroesophageal reflux disease. If it is between 4% and 6% of the time, then this is a borderline type of reflux disease. If it is less than 4% of the time with acid exposure, then this can be passed as normal. We're also interested in measuring the duration of the reflux episodes, all 4 types, the acid, the weakly acid, the alkaline, and the superimposed. And this would be, if we add up the duration, the bolus clearance duration as measured from impedance rather than from the pH changes, then all these periods added together would be much less than the period of acid exposure time. And the acid exposure time is more than twice as long as the bolus duration time in a 24 hours period. This is because the bolus can be cleared quickly by peristalsis or by gravity, but the acidity, the intraluminal acidity would remain a little bit longer, so the acid exposure time is twice the bolus exposure time. Now, how does this monitoring of the pH and the impedance over a 24 hours period correlate with what the patients actually feel, his own symptoms? Patients are given buttons to press to record all their symptoms and the time of these symptoms events. You will end up having a 2x2 table for periods in which there was a positive reflux and a positive symptom, no reflux but the patient had recorded a symptom, positive reflux and the patient had not recorded any symptom, and other periods in which there was no reflux and no symptoms. Now we are naturally more interested in this square when the patient had recorded that he had felt a symptom and there was actually some reflux. And this is the basis for 2 of the indices that correlate the monitoring results with the patient's symptoms. The first is the symptom index, the SI. This is obtained by dividing the number of occasions the patient felt that there is he has symptoms and there was actually positive reflux, divided by all the times the patient had pressed the button that he had symptoms, including times when there was no reflux. And if this ratio is more than 50%, then this is indicative that the patient's symptoms are related to the reflux. The other way of looking at this is to divide this total number of symptoms, positive symptoms and positive reflux, by all the reflux events, including other events of reflux that the patient had not indicated that he had felt any symptoms. He had no symptoms in here when there was actually positive reflux. And again, that's another way of measuring how much of a correlation between the patient's monitoring and the patient's symptoms. The best way of obtaining a validity between the monitoring results and the symptoms is the symptom probability analysis, in which we take into account the numbers in the 2x2 square and do one form of a chi-square test, Fisher's exact test, 2x2 Fisher's exact test. And if it is positive, that's to say the chances that these symptoms were associated with positive findings in less than 5% by chance, 95% confidence that the symptoms are related to the patient's monitoring results. Two other indices were recently found to be of clinical relevance. The first is the mean nocturnal baseline impedance level, the level of the impedance during the time the patient had marked as being asleep. Now, we know that injury to the mucosa of the esophagus or the pharynx by the reflux would increase its permeability, and this would decrease its impedance. So if the average impedance on this time of his sleep had dropped from, say, 3,000 ohm to less than 2,300 ohms, this would mean that there is suggests that there's some mucosal injury due to reflux disease. The other index of interest is the post-swallow peristaltic wave index. This is based on a natural phenomena that following a reflux episode, there would be a primary peristaltic wave designed to clear the pharynx or the esophagus from the offending liquid or gas to prevent further damage. This is a natural thing in normal individuals and should be found in after most of these reflux episodes, a small decrease in the impedance level going from upwards downwards, that is to say from the upper esophageal sphincter downwards to the lower esophageal sphincter to clear the lumen from the offending refluxate. Now, if the number of reflux episodes with the primary peristaltic wave are less than 1/4 of the total number of reflux episodes, then this is a low index, and it suggests that there is impairment of the chemical clearance of the lumen from the refluxate and increased reflux severity. And finally, laryngopharyngeal pH and impedance monitoring is an invasive technique involving transnasal insertion of a catheter. It's also costly to carry out, and it's poorly tolerated by a large number of patients and entails that the patient reduce or even stop their anti-reflux medications for a week before the test. Why should it be indicated? It is indicated in patients in whom surgery is required to control the reflux, because any surgery for reflux disease, the monitoring should be done to establish a concrete evidence of the reflux. It's also used to confirm an unclear diagnosis or in cases who are refractory with troublesome symptoms that cannot be treated by the maximum dose of proton pump inhibitors and alginate. By this, we come to the end of this presentation on pH and impedance monitoring in patients with laryngopharyngeal reflux. Assalamu alaikum.